I'm Dr. R.K. Shimpi. I'm a urologist, andrologist, and a robotic surgeon based in the city of Pune. And I'm attached to various hospitals in the city of Pune and one hospital in France. Today we'll be discussing prostatic diseases. All of you know that the prostate is a male sex organ situated at the neck of the urinary bladder. In health, the size of the prostate is about 2 to 3 centimeter and the weight is around 10 to 15 gram, but it grows with age and can achieve even the size of 300 grams. Prostate secretes certain fluid which is responsible for the nutrition of the sperm. In addition to the sperm nutrient, it also produces a glycoprotein called PSA and also prostaglandins. And that's a important tumor marker for the prostate cancer. So prostate is situated at the neck of the bladder. In fact, it engulfs the urinary passage. And these are the seminal vesicles, and the common ejaculatory duct opens on the prostatic urethra. So this is the schematic diagram. This is the urinary bladder, and this is the urethra. This is the bladder neck, and the urethra traverses through the prostate. And here you can see on the lateral aspect, the prostate is situated in front of the bladder. This is the duct of the seminal vesicles and the vas, and together they form the common ejaculatory duct and opens into the prostatic urethra. And this is very important because after the surgery, you cut the prostatic, the internal valve and the bladder neck, so the semen goes back into the bladder. That is called as retrograde ejaculation. All prostatic surgeries, you get retrograde ejaculation. Now coming to the diseases of the prostate, there are mainly three: the prostatitis, which occurs in the younger age group; BPH, the benign enlargement of the prostate, which is usually seen after the age of 50; and cancer of the prostate. Prostatitis is basically infection in the prostate, which can be because of the sexual act or because of the urinary tract infection. And initially, we should give full course of antibiotic for 7 days. And once the symptoms are reduced, then you can give them low dose antibiotic for a month or two. In chronic prostatitis, you have to give long-term medication, as all these antibiotic doesn't reach in prostatic tissue because of the prostate blood barrier. But this usually occurs in the younger age group. Now coming to the most common disease called BPH, where there is enlargement of the prostate, which is age-related enlargement, and usually seen after the age of 50, but the symptoms are usually seen after the age of 60. Cancer of the prostate is usually in the 6th or 7th decade, and the incidence of prostate cancer is increasing in India. As I told you, BPH is usually seen after the age of 50, and about 20% of patients will be treated with medication and they may not need surgery. But almost 60 to 70% or almost 80% of patients eventually will need prostate surgery at some time or other. The medical treatment will postpone the surgery for a few months to a few years, but ultimately these patients may need surgical treatment. One must remember that BPH is not the precursor of prostate cancer. And after the surgery of the BPH, we remove only the obstructing part of the prostate, and thus the shell of the prostate remains, where you can also develop prostate cancer. So even after the surgery of BPH by endoscopy, these patients can still have chances of prostate cancer, so they should undergo the serum PSA level every 6 months. So these are the risk factors: the increasing age. As I told you, this is the aging process; obesity, lack of physical activity, erectile dysfunction, and the history of BPH. These are the risk factors for benign prostatic hyperplasia. Now, what are the symptoms of BPH? Because of the prostatic obstruction, you can have weak stream, urinary weak stream. They will take long time for passing urine. They will have hesitancy, that means initiation of urination will be difficult. They'll always get a sense of incomplete voiding because they're not voiding urine completely. Because of the postural residue, they will get recurrent urinary tract infection. Because of congestion in the prostate and because of the congestion in the trigone and the bladder neck, they might have hematuria. Now, whenever in a stage comes when all the muscles of the bladder, they fail to contract, and these patients will have urinary retention. Now, when a patient of urinary retention comes to us, initially we put the catheter, give them alpha blockers and antibiotics, wait for about a week or two. After that, remove the catheter, and if they start passing urine with a good flow, they can continue with the medication. Because of the large postural residue and the nidus formation because of the desquamated cells, these patients can also develop bladder stones. So how do you evaluate a case of BPH? Initially, you should go for medical history, find out how many times they are passing urine, how many times they are passing urine, especially at night, what is called as nocturia. If the frequency is more than 2 or 3, then it is called nocturia. Whether they have any hesitancy in passing urine, whether they get urgency of passing urine, whether they leak urine before they go to the loo, whether they get burning while passing urine, whether they get bleeding in the urine, or whether they had any history of instrumentation, or whether they had urine retention in the past. So this medical history is very important. After that, we go for the physical examination. After general examination, you just check the abdomen, whether the bladder is full or not, whether the kidneys are palpable. Then you do the digital rectal examination, which is the most important test for the BPH. In lateral position, you pass a gloved lubricated finger into the rectum, and this will tell us about the size of the prostate, the consistency of the prostate. If there is hard, then there is a possibility of malignancy. If there are nodules, small nodules, discrete nodules, it can be because of granulomatous prostatitis. And if it is tender, then there is a possibility of infection in the prostate. At the same time, you can find out the size of the prostate, and at the same time, you can check the sphincteric tone, whether it is normal or not. Then you go for the urine examination, which will tell you about whether in the presence of pus cells. If it's more than 5, then there is a possibility that the patient might be having infection. In that case, you should send urine for culture, and accordingly, you might have to give him the antibiotics. The ultrasound examination, the PSA, uroflowmetry, and symptom assessment. These are the other evaluation tests. So this is how we do the digital rectal examination. We pass lubricated finger into the rectum and find out the size of the prostate. And in those patients where the PSA level is high, or those patients where the prostate is hard, you have to do transrectal ultrasound. So the abdominal sonography will tell you about the size of the prostate. It will also tell you about the full bladder capacity and how much urine the person is retaining in the bladder. It will tell you about the state of the bladder. Because of chronic obstruction, these patients will have trabeculations, saccules, diverticuli, bladder stone, and bladder cancer sometimes. At the same time, it will tell you about the kidneys, the upper tract dilatation, which can be because of back pressure changes, because of the large phosphorus residue associated with stones in the kidney, or if there's any evidence of infection like you get in chronic pyelonephritis. Now, those patients where the prostate is hard in consistency, or nodules felt in the prostate, or if the PSA level is high, you can subject them for transrectal ultrasound, which will also tell you about the size of the prostate, and if there are any suspicious lesion, at the same time you can go for the biopsy of the prostate tissue. Now this is the machine we use for ultrasound, and this is the probe used for the transrectal ultrasound. Now PSA is a glycoprotein secreted by the prostatic cells, and in health it is less than 4 nanogram per ml. The velocity is equally important, because suppose a patient comes to you with a PSA of 4, and after 1 year when he comes and the PSA is 6 or 7, then there is a possibility that patient might be having prostate cancer. Now, in addition to the prostate cancer, there are other conditions like prostatitis, which can be acute or chronic, the prostatic operations, biopsy, digital rectal examination, prostatic infarction, any instrumentation like catheterization itself can cause rise in PSA, any kind of surgery. So what are the indications for the treatment? A poor symptom score, the bothersome symptoms, like they have increased frequency of urination, maybe 4 or 5 times at night. They take long time for passing urine. Those patients who have resistant urinary retention, those patients who have bladder stone, those patients who get recurrent urinary infection because of the large phosphorus residue, or hematuria. So these are the conditions which will, in which cases we have to start treatment for these patients. Normally we do uroflowmetry. Uroflowmetry, if the flow rate is less than 10 ml per second, then there is considerable obstruction. If the flow rate is between 10 to 15 ml, you can try medication for these patients. There are alpha receptors which are present on the prostatic capsule as well as prostatic tissue at the bladder neck. So if you have any drug which will relax these receptors, these are basically adrenergic receptors. So if you have any alpha blockers like tamsulosin, cellulose, alphazosine, which are super selective alpha blockers, because alpha blockers are also present on the blood vessels, but these drugs mainly act, like 90% of them will act on the bladder neck and prostatic tissue. So this relieves the irritative symptoms and the obstructive symptoms to some extent. Now, there is another group of drug called alpha reductase inhibitors. These act under androgen synthesis and they reduces the size of the prostate, but it takes a long time, maybe 5 or 6 months. And the examples are the finasteride and dutasteride. And in addition, there are phytosteroid or herbal medicines like pygenal, which also helps to some extent in relieving the prostatic obstruction. So, what are the indications for surgical treatment? Now, those patients who have bothersome symptoms, which I mentioned to you earlier, they have a lot of frequency, they take a long time for passing urine, they had history of urinary retention, they have recurrent urinary infection and retention with a large phosphorus residue, those patients who are getting recurrent hematuria, or those patients who have bladder stone. So, what are the treatment options we have? Nowadays, open surgery is almost absolute. We have endoscopic surgeries, and the gold standard is transurethral resection of the prostate, what is called as TURP, which has stood the time till now in last almost 100 years. Those patients who have only bladder neck obstruction, where we go for the transurethral incision over the prostate. Nowadays, most of the time, instead of going for TURP, we use laser for the prostatic surgery. Like holmium and thulium lasers are used to enucleate the prostatic tissue, and this enucleated tissue is pushed back into the bladder, and with the help of modulator, we cut the piece of prostate into small pieces and remove it. The green laser is used for vaporization of the prostate for those patients who are on anticoagulant or those who are high risk patients where surgery per se is not possible. In that case, we use green laser and vaporize the tissue so that they get relief from the obstruction. Now, those patients who are absolutely not fit for the procedure, we put the prostatic stents in the prostatic urethra, or we can go for the resume and a hyperthermia. And nowadays, we insert patients, we can go for the prostatic arterial embolization, which does not cause retrograde ejaculation. So this is the example of this is how we do the transurethral resection of the prostate. Now this is the median lobe, these are the lateral lobes, this is the cutting loop. So with the help of cutting loop, which is activated by foot switch, we cut the prostate into small pieces, and these pieces are later on removed through the same endoscopes. And this gives almost 90% good results, and it has stood the time. So slowly we keep removing the pieces, and if there are any bleeders, we coagulate it with the same cotton loop by using coagulation current. This way you can create the prostatic fossa. And then these chips are then later on removed with the help of endoscope. Now this is how we do the resection using the laser. Now this is the laser fiber. So you start cutting at 6 o'clock, and this is a pretty large prostate. So you start at 12 o'clock, make an incision, and then enucleate the lobe, which is then pushed back into the bladder. And later on, with the help of modulator, you can cut the lobe into small pieces and remove it. Here with the laser, the bleeding is very less unless you open the sinuses. This is how we enucleate the prostatic lobe with the help of laser fiber. And then it is pushed back into the bladder, and with the help of modulator, you remove the prostatic tissue. This is how we do the resume. So as I've told you, the prostatic obstruction needs relieved by surgical techniques. I've mentioned all the surgical techniques like TURP, laser, resume, and urolift, etc. And it's a pretty safe surgery nowadays, especially with the lasers. and the complication rate is very low. Normally, you get bleeding or a stricture formation, which the incidence is less than 2 to 3%. And thank you.